Good afternoon, everybody. Welcome back. We hope you had a chance to check out our sponsor and exhibitor booths earlier during the extended break. It's now my pleasure to welcome Mike Edbauer, president of Highmark Western and Northeastern New York, who's going to introduce and moderate the discussion for our next panel, Consumer Decision-Making in Healthcare, the Role of Transparency. Good afternoon, Mike.
Afternoon, Eric. Happy to be here. Thank you for inviting me today. So I'd just like to be able to start our introduction of our next panel. Happy to be here and be able to moderate the discussion. And we're going to be looking at the current efforts to empower consumers, how effective they are in helping them make informed decisions about the care they receive, and what additional measures are needed to help address systemic racial and ethnic inequalities in healthcare. We're going to start this afternoon with a session with a presentation by Andréa Caballero, the program director at Catalyst for Payment Reform. With over 18 years of experience in the healthcare industry, Andréa leads CPR's work in tracking and quantifying progress in payment reform. Prior to her joining CPR, Andréa served as vice president in enterprise and health services policy for United Health Group. There, she worked on a range of healthcare policy issues at the state as well as federal levels, and was also a member of Pacific Care's public affairs team as a director of state government relations for the Western region. Also joining us today is Hemi Tewarson, executive director of the National Academy for the State Health Policy, a nonpartisan forum of policymakers throughout the state governments learning, leading, and implementing innovative solutions to health policy changes. Hemi joined NYHPA from Duke Margolis Health Center for Policy, where she had been leader of the center's emerging state policy. Hemi, sorry. This included the work addressing the equity beyond the COVID-19 testing, containment, vaccine distribution, education coverage, and health system reform, Medicaid system improvements, and addressing equity within and beyond COVID-19 pandemic. She also previously served as the director of the health division at the National Governors Association Center for Best Practices. Also joining us is Jeanne Pinder, founder and CEO of ClearHealthCosts, a journalism startup in New York City that is bringing transparency to the healthcare marketplace. Previously, Jeanne worked at the New York Times as an editor, reporter, and human resources executive for 25 years. She took a buyout in 2009, and a year later won a Shark Tank type pitch contest at the CUNY Graduate School of Journalism to found ClearHealthCosts. More detailed information on our panelists is available by clicking on the speaker icon. So first of all, welcome to all the panelists. And now I'd like to turn the session over to Andréa before we get to our panel discussion. Andréa?
Thank you very much, Mike. Can someone confirm that you can see my screen? I think you can, but I just want a thumbs up.
Yes.
Great. So thank you, Mike, for the introduction. And thanks, Eric, and to HPA for inviting me back again for my third year. It's really been an exciting year. It's been, we've all had really a lot of challenges over the last 2 years, and it's hard to believe that next week is Thanksgiving. But thank you for attending, and I look forward to discussing this with my fellow panelists, Jeanne and Hemi. Let's see, my page down is not working. Okay. Well, since this is my third year, perhaps many of you already know a lot about CPR, so I'll be brief here, but we are a membership organization that really is committed to empowering purchasers to change the healthcare system. You can see some household names here who are our members, but we have a range from Fortune 500, Fortune 10, public and private, state Medicaid agencies, active and retiree agencies, as well as the university and some trust funds. So we have a diverse group of members, and they are all, what they have in common is they're incredibly innovative with their healthcare benefits and design and payment innovation. In total, the group covers more than 15 million covered lives and over $80 billion in healthcare spending. I won't go into all of the things that CPR does. Today's conversation is about transparency, and it really falls into that first bucket of education, and also providing tools and support for purchasers as well as other stakeholders. But these are the range of things we do. I primarily focus my work in the research side. Some of you may have seen the New York State scorecards that we released in early 2020, both in the commercial market and in the Medicaid market. So if you haven't looked at those New York specific scorecards, I encourage you to take a look at them on our website. You can make sure that the group has them. So on to the topic at hand. And we sort of start with the why do we need transparency in healthcare prices? I've kind of broken this down here into 4 stakeholder groups. We have the individuals or the patients or the consumers, they're people, as Jeanne will remind us that these are people. And then our constituency, CPR's constituency is purchasers. And of course, there's a need for transparency with providers and also with policymakers. So I know our panelists will go into detail about each of these constituencies and their various needs and what their demands are. I know the purchaser voice well, and I'm level setting here, but I think it's just important that, of course, patients, individuals do have the right to know in advance, to the extent that this can be known in advance, what kind of price information is available. Unfortunately, it's not always available in a usable format, nor is it consistent across platforms. We'll hear a lot about how motivated consumers are in using price information and quality information. And when it's made available, I think we'll see that consumers do shop, but not in the same way always that we see in other sectors. From the purchaser point of view, obviously, rising healthcare costs are front and center. 2020 was different in the sense of low utilization, but purchasers need information about price as well and quality in order to understand how they should create their benefit designs and work with their health plans or TPA in developing a provider network. Providers, one hopes that they could use transparency in terms of making informed referrals to minimize the total cost of care as well as the cost of care to individuals and their patients. And finally, on the policymaker side, it's a pervasive myth that prices and quality are related when they are not related. And I think we all have a role to play in educating and exposing when there is extreme price variation, even if it's not that extreme, but it may be unwarranted. And this can be to an imbalance of market power. And this might be when policy intervention is needed and when state and federal intervention is needed. So I'm going to transition here to, what is the state of transparency in healthcare prices. You can see here, we've got a lot of activity on the federal level, at the state level. Of course, health plans and private vendors have their own tools. But in that last point of exposing price variation and looking at market power and how prices may vary wildly within a geography and across geographies, we have the RAND hospital price transparency studies. So I just wanted to, I'll go into a bit of detail on the federal transparency rules, but obviously there has been a great deal of activity federally, which hasn't been, common. This is a relatively new activity for the federal government and for federal agencies. On the state level, there's always been some activity, and it varies in terms of what that activity looks like. But we do have 18 states now that have implemented mandatory APCDs, or all payer claims databases, Hemi, I'm sure, has lots of insights into those, and they aren't a panacea. So while states may have these databases, I'll talk about some of the limitations with them. And then there are 8 states that make price and quality information public directly through public websites. Health plans, their transparency tools are ubiquitous. I started studying this back in 2013, and the tools were not always available by health plans, but fast forward, and all health plans have either their own proprietary tool or they are working with some vendor who will make price information available. There are limitations, though. There are always contractual prohibitions. There sometimes are limitations with the number of patients as more gets to the quality side. But there are gaps in these health plan tools, and so but they are available. And then finally, we have the private initiative. This is the RAND Hospital Price Transparency Study. This was an employer-led, purchaser-led initiative to really expose the variation in prices and make them transparent and start a dialogue around why are the trends are what they are. So federal, state, health plan, employer, all are active in the transparency space. So we know that health plan tools are ubiquitous, and they have a variety of information. We haven't really studied this since 2018, since most health plans, all health plans have some form of tool. But in 2012, when I started at CPR, we had our first call to action on transparency. And then in the summer of 2018, after we last studied health plan tools, we actually did a, Jeanne might appreciate this, based on reporter inquiries, we did some secret shopping exercises and had use cases where we would look at different tools based on these use cases. And it really revealed that there is still a lot of missing data for consumers to use. It's either not there or it's difficult to navigate. And it's always, the onus is on the patient to know their exact procedure when in fact, that isn't always the case. As I said, we last studied health plan tools officially in 2018. CPR released our last state price transparency report card in 2020. We started in 2013. Our last was in 2020. This report is available. It shows you our methodology, but in general, you can see that most of the country still receives an F on the criteria that we applied to state policies and state laws. So there is some progress. You can see over time, we have some that have moved up from Fs to Cs to some Bs and a D if we're grading on a curve here. But there still is really kind of slow progress at the state level, depending on what, the criteria we use may be different than how others measure the effectiveness of state policies, but I know that Hemi will be able to weigh in there. Very briefly, if employers can't find appropriate information for their employee population and their dependents, there's a wealth of vendors out there who have independent transparency tools and navigation support and second opinion. I don't have ClearHealthCosts on here, Jeanne, because it's not a direct to employer per se. These are really direct to employer tools, but this is, it shows that there are a lot of tools out there and there is availability of information, but it varies widely on the need. And it also, they all have their niche and where they're getting their information. Of course, we don't want to talk about transparency without also talking about quality transparency. And, this has been a passion of CPRs and our executive director for a very long time. There are actions at all levels, federal level, at the state level, federal with Medicare and hospital compare, state level, there are some states that have public websites. Some are using their all payer claims database to populate those websites or provide quality information reports. Health plans and private vendors have some quality information, but it is very inconsistent. And this is where health plans usually have a difficulty doing quality rankings on their tools, because the N, or the number of patients to grade quality for a particular provider, may be too small, and so it's not reliable. And then, of course, we have the nonprofit sources like the Leapfrog Group and their safety grades, who make some quality information public, to the extent that there's participation from the markets sector in participating. So this is where we get to some of the tension around transparency and the federal action that has been taken. So in November of 2019, CMS did issue its final rule. I don't think I need to explain to this group that the compliance with the rules and the requirements is very low. Either hospitals are slow to comply. In some cases, there's actually active non-compliance, because the penalties for not having this information available is really quite low. There has been a recent change in that, where the penalties are increasing. For large facilities, the max is just over a $2 million penalty per year. But at the end of the day, we have a federal rule and requirements for hospitals to make standard charges public, including payer-specific negotiated charges, but there's just non-compliance. And even if there is compliance, well, I guess I can't even say that it's compliant. If it's not machine readable, which even if you have information on your website and it's not machine readable, that is actually technically not compliant as well. So we have a ways to go here in terms of enforcement of the federal transparency rules on hospitals. And there's equal opportunity here in terms of the imposition of federal action and transparency on health insurers. Come a year later, but we do have requirements from HHS and the Department of Labor and Treasury, which they finalized the health plan transparency coverage rule. And this is a little bit tricky in the sense that it requires health insurance, but also group health plans, which is putting in a requirement on self-funded employers, so many of the CPR members, that there should be an online member-facing price comparison tool. Again, machine readable, and it has to include in-network negotiated rates. We have some deadlines here, which continue to be extended. There are concerns about accuracy of the data and making sure that we're not putting out information that are member-facing, that can be compared, that isn't accurate. So it's really about making sure that things can be done on time and that it's accurate. But there are requirements that there have to be good faith estimates provided to the insured and uninsured by providers and facilities. This is a little bit tangent from the health insurer, health plan side, but there isn't going to be enforcement on this right away. But we've seen kind of lack of enforcement on the hospital side. So we'll see where this one takes us. You also have federally the Consolidated Appropriations Act. Lots of states have implemented this rule on a state basis. We now have it federally, which is it prohibits insurers from agreeing to gag clauses in their contracts with providers, and this applies to both prices and quality. And then, of course, we can't talk about federal action without talking about the no surprise billings, and we've got the provider directors must be up to date regarding the network status, and there's no balance billing allowed if participant is incorrectly told a provider is in network. New York has led in a lot of these areas, and so I don't want it should not be lost on us that New York has actually made some strides in some of these federal areas. I won't go through the timeline of this. You all are experts in what has been going on in New York, but notably, New York was early to adopt its Emergency Medical Services and Surprise Billing Act. This was back in 2014, and then it updated it in 2019. So, I think that New York was a leader in that. And there are also some other things here in terms of transparency that New York has tried to implement policies. Some have probably been more successful or advanced more than others. I think there are probably some concerns about the APCD and the New York Healthcare Compare websites. So there's work to do, but even as recently as this year, you can see here that there are bills or were bills that ban anti-competitive hospital contracting practices and gag clauses, a la the federal rule. So I'll leave, sort of close up here with some state policy trends, and our panelists will talk about this, but there are more and more APCD bills and laws coming into effect at the state level. And this year is the, one of the first years where we saw a lot of momentum around cost benchmark bills and laws. Indiana enacted one. And this, these cost benchmarks bills are pretty interesting in terms of how state legislatures and state policymakers are engaging on trying to contain healthcare prices. Of course, there's a lot of activity around anti-competitive contracting. We talked about the federal and state gag clause rules and making sure that there's a level playing field and there aren't all or nothing contracts, that they're anti-steering, anti-tiering bills are very much making their way through state legislatures. And of course, there's still the right to shop laws and bills, surprise billing, which may be less of a factor at the state level now than federally. And of course, we can't really talk about transparency without talking about drug pricing and transparency there, which is limited. And I'll talk about this during the panel discussion if needed. This is really about the guidance that CPR gives to purchasers when it comes to transparency and transparency policies and the actions purchasers can take with their health plan, with their facilities. How do you hold the system accountable for ensuring that purchasers and patients have what they need when it comes to price and quality information? So thank you again, Eric, and to HPA, and I will turn it back over to Mike for the panel discussion. Thank you.
Great. Well, Andréa, thank you very much for your insights. That was a great overview. Really appreciate that. Before we kick off the panel discussion, I just want to remind all our attendees that if you want to submit a question, down at the bottom, there's the Q&A portion, and you can put your questions in, and we'll do our best to get through all the questions that come in through the rest of the time today. So with that, we'll move over to our panel, and we'll start by kicking off here to ask, what would you consider to be the right kind of transparency? That's most meaningful to the consumer, employers, or policymakers, or kind of put it another way, what does transparency mean for the folks that you represent?
Yeah, I'll take that one. I speak as a journalist, and as a journalist who talks to a lot of patients, consumers, or as we like to call them, people. They are outraged, they feel betrayed. I'm actually surprised that they haven't come out with pitchforks and torches yet at the idea that maybe that MRI that they paid $6,000 for, they're actually able to get for $300. So this blooming of transparency, which truly has taken a little bit longer than we thought when we started doing this, it's here now and patients can see it. People know what's going on. And I think there's just this tsunami of feeling across this nation about this topic.
Thank you, Jeanne. Hemi, I was curious your thoughts on that as well.
Yeah, no, I'm happy to share. And thank you for having me at this conference. And I very much appreciate both Andrea and Jean's perspectives here. So I am from the National Academy for State Health Policy. And just a moment so people understand my perspective. What we do is we are a nonpartisan, nonprofit forum for state leaders. And we work closely with them as a trusted partner on really advancing their policies. And that ranges from state legislators to governor's offices, to Medicaid directors, to public health officials, and to those state officials overseeing social services. So it's a really broad cross-sector way of working with states. And I will say one of the things we really have been focusing on is all our work is done, at the request of states. What are state priorities and where do we really need to help them find new ideas? And I would say that the past couple of years before the pandemic, there really was, consumers, to Jean's point, were coming out and, going to their legislators and their governors and saying, look, what are these prices on the drug pricing? My hospital bills, I'm getting surprise bills. We need help. And, on the political level, leaders were running on, platforms to say we are going to bring down healthcare costs. And so, that has evolved into, okay, what do you really do with that with respect to state policy? And just to provide my perspective on that, there are two areas that state leaders have really been honing in on, and that's drug pricing and health system costs. Those are the two biggest drivers for not only because, states are purchasers and policymakers, right? So from the purchaser side, from their budgets, they're spending a lot on the drug pricing and the health system cost piece, but they're also hearing from their constituents about those two buckets as well. And so that has really been the focus of their work. And I will just say sort of big picture, those are two really hard areas to take on. And I do think a key to this, and this is from sort of the state policymaking side, is we need more transparency to understand what are the cost drivers and get people sort of on board so they're able to sort of take on the political battles to really do what's needed to lower drug pricing and prescription and health system costs. I'll say on the consumer side, I think a part of what's challenging is, state policymakers are looking at how do we have reforms, that will like really bend the curve in what the cost is for health system costs and drug pricing, and then eventually that will lower premiums presumably for consumers in their various health insurance markets. That's a longer term game, and it's hard for consumers to really feel that as state policymakers roll out these really complicated ways to try to really control costs. And so I think there's also this pressure to address, well, how do we help consumers now? And how do we really address their concerns? And I'll just, and I'm happy, Michael, as we get into the discussion of, providing some examples of where we're seeing sort of emerging policy areas, both on policymakers wanting to have more transparency across the system and then helping consumers. So happy to take this any way you like.
Thank you. Thank you. And I do, Jeanne, want to come back for a second with, you talked about, how people are feeling out the public, right? And I think everyone would agree that, there is that certainly very strong sentiment. And Hemi, you talked about it, that we're seeing it even in the political with some of the elections, et cetera. I guess one of the things is how effective are the existing online transparency tools? So there's been some development. Andrea talked about some of the things that are out there. I'm just curious your thoughts on how effective those are at the present time.
They're not very effective at all. Thank you for asking. It's just, and even the existing transparency tools that predated the recent legislation, there's no accountability. They're hard to use. They're wrong in a lot of cases, both on the hospital side and on the health plan side. We hear this all the time from people who say, well, I asked in advance and they told me 200. Where did this $5,000 bill come from? And I think one of the things that we've noticed that's very interesting in the 10 years that I've been doing this is to see that it used to be that people didn't want to talk about this, that people were kind of embarrassed to talk about medicine and money at the same time. They felt like maybe they were going to be shamed by their doctor, or, that the state of their checkbook shouldn't be a public discussion topic. But increasingly, people are just outraged about this and they want to talk. They'll talk to anybody, including telling us as journalists their most intimate personal details of their medical treatment, which then translates into journalism, which can translate into legislation. So for example, in New Orleans, we did a very splashy partnership with WVUE, Fox 8 Live, and NOLA.com, the Times-Picayune, where we did a consumer-friendly investigative series about healthcare pricing and people who felt that they'd been taken to the cleaners when they went to get their MRI or get their diagnosis of frozen shoulder. We did a series of stories that at the beginning of our partnership, the insurance commissioner of the great state of Louisiana came on the air with us and said, balance billing is the most unconscionable consumer abuse anywhere in this nation. It's horrifying. I've had a bill up on the legislature in Baton Rouge for the last 10 years. I've given up on it. He said, legislators will not go against Blue Cross Blue Shield of Louisiana and Our Lady of the Lake Hospital. We launched, and 9 weeks later, that balance billing bill passed by the convincing margin of 100 to 1. So I think it's, making people aware of what it looks like. The legislators may not have known. They may have felt that people were insulated from health prices by some sort of regulation or sensitivity to the fact that people are being taken to the cleaners. When they realized what was going on, they passed the bill.
Thank you. Well, and kind of following up with that, then, as we look at where some of the shortcomings are, and this really for any of you or all of you may have a view on this as well. So with the No Surprises Act coming down, how confident or perhaps skeptical are you that it's really going to make a difference in what we're trying to achieve with truly greater transparency?
I'm happy to just offer some remarks on this. So, we were working when I was at the National Governors Association, before I was at NYHPA, we were working with a number of states that were, passing and enacting surprise billing laws. New York, as Andréa pointed out, was kind of, early on in the movement, but a number of states followed. And I will say they had a lot of battles, as Jeanne described, of really having to work it through the legislature and then figuring out how to implement. And some of it was like, how do you negotiate what the right price is at the end of the day? And there are different stakeholders that had different, I think, weight in terms of what they were able to accomplish in different particular states. So I'm happy that there is a federal law that has at least a floor, right? Of like, here's how everybody has to comply with this. And there are states then, of course, who want to do more, and then they're enacting additional legislation for the particular gaps that they're finding in their states. But I think it will be helpful. Not all states took this on, obviously, either, because of some of the politics and sort of do you have a leader in your state that's going to really want to do this? So I'm actually pleased that this has moved forward, and I do think it will help. I will say this though. I think it helps the consumers on the balance billing issues and the surprise billing issues. It does not help on how we reduce cost across the board. And, that is what my concern is. Like, we have to protect the consumer, but we also have to think holistically about what we're doing with the healthcare system. And so if there's one place where, they're not going to, pass costs on to the consumer, is that cost going to be moved elsewhere, whether it's in premiums or elsewhere? So, I do very much believe in a holistic view of how to take on some of these approaches, and that, that's what I was hoping to do.
And,
Yeah.
sorry, go ahead, Jeanne.
No, go ahead, Andréa.
Well, I was just going to say that, in this issue of, taking the consumer out of the middle on these bills has been around for a long time. I've been at CPR for almost 10 years now. And prior to that, with my health plan hat on, these bills were in the legislature at that time, and they were true battles. So I share Hemi's, support that there's a federal action on this and that there's a floor. But how it translates into transparency is really unclear, because you are going to have, a dispute between, what's the right price to pay for this service. And the way the federal law works is that both come in with, their price, and there's certain, there's a negotiated price perhaps, or average. And then maybe, fortunately, I think the federal law is not, the rules do not allow billed charges to be considered, but the arbitrator can't pick anything in the middle. Like, they can only pick one or the other. And so there's the potential, and in some states that have studied this and have had no surprise bills, like if the arbitrator continues to select the higher price, payment, that could raise prices entirely. And will we actually have a lens and a view into what those are? Maybe over time, once there's more disputes, although no one really wants the disputes to go into effect. Go ahead,
And
Jeanne.
I'll just jump in and say, the interesting thing about the federal law is that people keep emailing me and calling me and saying this solves the problem, right? And I'm like, whoa, wait a minute, whoa, not even half, because it does address the idea of surprise billing. Let's say if I go to a hospital that's in network and I get an out-of-network anesthesiologist, but it doesn't address all of my in-network bills, which could be equally surprising if I have a $15,000 deductible, which I easily might. And those bills are very surprising, and there's nothing in the federal legislation that touches that, to Hemi's point.
So still a lot of work to be done
yes.
in that area for sure.
Oh, yes.
I am also curious the view of you all relative to, as over the last 18 months, we've been experiencing the pandemic and all the challenges that COVID has brought. So some of this work obviously was started well before COVID came on board. I'm just curious your thoughts. Has COVID actually accelerated the work around the transparency on the cost, or in fact, has it created some hindrance to the efforts to move things forward?
I'm happy to start. So I think, for at least from my perspective, from a state policymaking perspective, there has been continued interest, but it did slow down last year. And that's just really state official bandwidth and the ability to really have resources to kind of move sort of big policy agenda issues when, half the state officials are focusing on pandemic response. So, purely out of, capacity and political will, it was a challenge. I will say, we do our state meeting every year, and we had, I think, over 500 state officials come to our RX and Health Systems Cost Summit, because there really is an interest in how do we get our arms around this. So I do think 2022 is going to be a busy legislative year to figure out how we, get our arms around transparency and health system and RX costs more broadly. I will say, with respect to prescription drugs, I think, frankly, the states are a little bit farther ahead in terms of thinking about transparency on that front. And some of the transparency, just to be clear, is transparency for the policymakers and the broader sort of public at large to understand what we're talking about in terms of high cost drugs, and not necessarily transparency specific to the consumer. So there is a distinction there. And I think you need to have both, because you need to have the will to kind of, move the needle on things like, unsupported price increases, and thinking about international reference pricing, and, where there's opportunity to address pharmacy benefit manager reform. You need all of those pieces of more transparency to understand where the issues are. But I think there's a separate piece about how do we help the consumers. And on the consumer front, I will say there's a couple of states where they really are trying to focus on consumers, like in Oregon, where they really want, okay, you have to actually tell the consumer where you're going to actually raise your prices for drugs. And then they put that out publicly. There's, I think, also sort of reform on one side where they're saying, okay, we need to actually have some impact for consumers so they understand kind of what's happening in the market. I don't know how effective that's going to be. Drug pricing is very complicated. But I do think the gag clauses that Andréa talked about earlier have had more interest in states. And, there's a federal law that is, again, a floor, and states have, legislated above that to say, pharmacists, you can actually tell a consumer if their insurance it's going to end up costing them more to use their insurance to cover a drug. You need to tell them, and what are the other, lower cost options that they have. So, I think we're seeing movement on that. I'll say one more last thing on drug pricing. Insulin has really got national attention. What people are paying for insulin has it's on fire across the states, right? I think there's now 14 states that have enacted legislation, plus Colorado being the first state to say we have to cap copays for people who have diabetes and need insulin. And now we see it in the federal bill, right? We'll see if that passes. So I do think that There are some permutations in the drug pricing world that's getting to consumers, but not all of it. We're still at kind of this like, threshold of, can we understand a little bit more about how the drug pricing world works? And then one more comment, then I'll let others talk. On the health system cost side, I will say it's been a tough time to take on hospitals. Hospitals have been like on the forefront of this pandemic. They are still struggling. They're having problems with like staffing, people who are going in for emergency room visits who are not, COVID related, can't get a bed. I mean, there's a lot of things happening. And so it's really hard for policymakers to take on like, well, you're charging people too much. We're spending too much on your, cost, and we got to bring that down. So just from a political level, we're focusing our efforts on like the transparency piece of just like, let's highlight like how much money health systems have and where there is the ability to demand more change, even in the midst of them really like, being the warriors and the frontline folks that are helping all of us out of the pandemic.
Thank you. Jeanne, did you have some comments?
Yeah, so I was really interested to hear you talking about the lack of interest in health costs during the pandemic. So we pretty much pivoted in March 2020 from all health costs all the time to all COVID all the time, because nobody really cares about MRI prices, right? You're not getting an MRI unless you have to, more or less. And we've done a very deep dive into COVID pricing, which actually led us into some very interesting efforts. We're taking part in a vaccine distribution outreach program under a grant from the New York City Department of Health, which has been crazy interesting. But it did reveal a bunch of things, like the core of unvaccinated people pretty much tracks with the core of uninsured people in many areas in New York City. So it leads us to think about equity, people who are shut out of the healthcare system. In the neighborhood that we're working in Queens, there are 40% of the people there do not have a primary care provider. 40%. And the problems that led to this are the things that caused the pandemic to lay waste to huge areas of New York City. And I think addressing those problems is in a way more challenging, more rewarding, and more necessary right now than some of the health transparency stuff that we did before. Don't know exactly what our work is going to look like in the next year or two, but we do know that there's going to be a huge component of equity and advancing, reducing disparities and advancing access to healthcare for people who don't have it because they're uninsured, because they're maybe undocumented, because their deductibles are too high, and they're choosing not to have that MRI, not to buy those medications because they have to decide to either do that or put food on the table.
Thank you. And I think certainly one of the things that did occur throughout the pandemic, still occurring, is that people did become, I think, at a high level, more aware of the inequities in healthcare, right? Because we started to see that coming through with the mortality as well as the morbidity associated with COVID. And I am curious, obviously a lot of the work has been around pricing, but as we move forward, what role could we see for transparency to help with the racial inequalities related to healthcare, certainly within New York State, but even more broadly?
It's a really good question. I mean, we're going to have to decide whether systematically underfunding public health is a really good approach to a pandemic, because there will be another. We're not out of this one yet, and there will be another. So what do we think about those 40% of people who don't have access to healthcare because they don't have a primary care provider? They say, should I get vaccinated? I may have an underlying condition. The standard response from the system is talk to your primary care provider. Well, what if you don't have one? So changing those things, I think, is going to be a big task for all of us here.
Yeah. And I was just going to comment on a few things as well from the state perspective. So, a couple of things that we've seen, there's a lot of interest, to your point, I completely agree, on how do we really address the disparities that we see in healthcare and beyond healthcare. Frankly, it's across a lot of different areas that have been exacerbated by this pandemic. and they existed long before. I will say there's a couple things. One is the data itself. I think we need to have better data to understand where the disparities are and how we start to really be systematic and strategic in changing policy. And right now the data is not great, right? So that we've had a big improvement in the vaccine data for race and ethnicity. And, all of a sudden we have almost all the states reporting based on race and ethnicity. Beginning in February, there was probably like 5. I mean, we've made huge strides in that piece, but it has to start applying to a lot of different areas. I will also say in terms of the policymaking piece, I think states are really trying to figure out how do we move the needle on this? Where do we start to make the investments? There are a lot of dollars coming from the federal government right now, billions and billions. It's unprecedented. And state budgets are actually doing a lot better than we thought they would in general at this point in the pandemic, hopefully almost recovery, but not quite yet. So, where are we in terms of how to spend those dollars? And I think that's where some states have made decisions and others have not. And I think that is going to be a really important piece, because I really hope coming out of this pandemic, we don't all say, oh, we spent all those billions of dollars and we had no impact on addressing disparities, and we did not have sustainable change to access to care. And I will say from a state perspective, it's a little bit of a tough, quandary or, puzzle to solve, because it's shorter term funds. And so when you think about, hiring staff up and, building out a lot of different types of programs, there is a concern that there will be a cliff. And let's not do all of that if we know, after 2 years, we'll no longer have these funds. So there's a very difficult budgetary piece to build into all of this as well. So, but I do think opportunity.
So we touched on some of the issues related to cost, talking a little bit here about the disparities in healthcare relative to the racial disparities. And then Andréa, in your presentation, you really talked about the thing certainly quality we don't want to forget. And so I'm curious, the panelists, your thoughts on how we can do a better job relative to transparency as it relates to quality, and potentially how do we help advance that through our policymakers?
Well, I'm happy to say that the only thing that is broken worse than price transparency in healthcare is quality transparency. And we chose not to engage both of them because we're not medical professionals. We just don't have the chops to do it. It would be wrong for us to pretend to judge which is the best MRI. I will say that I had the privilege of hearing a dozen radiologists argue over this topic once in a ballroom in San Francisco when we rolled out our very first price check tool in front of a group of radiologists at a conference. We displayed the prices, the price disparities, $300 to $6,000 on that simple MRI. They erupted. One of them said, wait, you're commodifying our work. And one of the other ones said, well, they didn't do it. Somebody else already commodified your work. And then they began to argue about what makes a good MRI. Well, it has to be a really good machine. Another one said, well, if it's a good machine, but it's not maintained and calibrated, then it's a terrible MRI. Another one said, no, it's the technologist. It's the person that arranges the body parts and takes the picture. That's what makes a good MRI. Another one said, no, it's the radiologist. It's the person who reads it and tells what is a pathology or is there no pathology. And if that's a weak link, it's a terrible MRI. So they kept on in this vein. And then finally, one of them said, you know what? The worst MRI is the one that she didn't get because she felt like she couldn't afford it. And there was a big silence.
Andréa.
I'm not sure that I could say it much better than what Jeanne said. I think, many of you may know that CPR's executive director is Suzanne Delbanco, and she was the founder and CEO of the Leapfrog Group. And, Leapfrog continues to make strides, but there needs to be participation and cooperation and an interest in providing quality data so that it can be used. I know APCDs have their flaws. I think there are models like states like Colorado and Civic and how they're using data to look at state price and quality and how it's affecting different populations. So there's potential But collecting quality data or having, hospitals report quality information, just, as Jeanne said, if there is something worse than price transparency, unfortunately, it's quality transparency. And then you also, you have very real issues like, you can't assess a provider's quality or performance on something when they have a very limited number of patients, and that's irresponsible too. So there are real limitations, that have to be, acknowledged, but there's a lot that can be done on the quality front that isn't.
Yeah, and the only thing I would add is we're not there yet, but how do we work towards, population health metrics? So, instead of sort of focusing on the individual MRI that was done or not done, or, a particular provider, do we think that provider was high quality or not such high quality? What is happening at the end of the day for the patient or the consumer or individual? Have they done better? And I think there's a lot of challenges about, well, they move health plans, they change providers, who's going to be responsible for that person. But there are a couple of states, Vermont being one of them, that are really trying to, and Oregon, think about these population level metrics to hold the entire system accountable and pass that on from plan to provider. And I personally view that as a good direction if we really are going to, especially with, something like equity, are we doing better? Are people getting access to care? Is their health improving? Because otherwise I think we get stuck in this, and we've been in it a while, right? These, quality metrics that come out, HEDIS measures and all these are important elements, but is it really changing the health of the population? So.
Very fair.
I'll just add that, what Hemi is getting at here is that there's resistance to having to deploying and using patient satisfaction metrics, but that really is what's necessary. And is the patient satisfied, and is the patient from their perspective, has that person felt improved, and did they get the quality of care that they expected?
Well, going back, Andréa, in your presentation, you had the one graphic there that just showed, unfortunately, how poorly we're doing with transparency, the picture of the map there. I'm curious, Hemi, when you look at the work of the different states, is there anyone who's kind of leading the way? And, as we look to the future, is there, one or more states that we should look at to say where we can learn from and perhaps model moving forward? Or are we all unfortunately equally challenged at this point in time?
Yeah, and I smiled at that slide because I would never grade the state. So I'm glad that you can. That's a tough question because I think it's like transparency in which piece of the puzzle. And so, I think a couple of states are really far out there on, like drug pricing, for example. Other states, Texas, actually has done some interesting work on implementing the federal transparency rule and actually legislating themselves to actually enforce the federal transparency rule so that hospitals are actually complying. So that's been an interesting development. So I can't say that there's like one or two states that like, oh, look at them and they've got it solved. I really do think it's evolving. And, to really focus on the consumer piece, I think is the challenging part, because I feel like, states are taking on both, and a lot of them are focusing right on transparency more broadly for the market and the policymakers to understand where we need to move. So I'm kind of dodging your question, but I don't have the one or two states to really point to. It's like
that's fair. And unfortunately, I assume that's kind of what it was. If there wasn't somebody that was already all the way there, we probably would have heard more about that. But so I guess that's both discouraging and reassuring at the same time, right? We're all in this together, but we all have a lot of work to do. So I appreciate that. I know we're getting close to the end. I just wanted to check if we had any questions that had come in from the broader audience. If there's anything that has come in. If not, we'll continue here. So no questions. Okay, very good. So really, as we wrap up, I guess I would like to ask from each of you as we move forward, what would be the one or two takeaways that you'd be asking us as leaders in the community to work on as we try to have greater transparency across the board? I think that would be helpful to hear your thoughts.
I'll jump in, ever shy. We think that the best the best data set for pricing would include every price in the marketplace for every single procedure. That would be for the charge master price, the Medicare price, the Medicaid price, what's being paid to Blue Cross Blue Shield EPO, Blue Cross Blue Shield PPO, Anthem, Cigna, Humana, every price, every single price. We're absolutist on transparency. I cannot think of a cogent argument for all of this secrecy. People are being hurt by it. People are dying.
Thank you. Hemi?
I would say that support these ideas of really trying to get more transparency more broadly across these tough areas like drug pricing and health system costs. I think we need more champions, frankly, to get some of these like harder pieces over the finish line in various states, New York included, actually. And thinking about how, laws to at the state level to better enforce what the feds are trying to do, and really for example, transparency around like hospital prices for consumers. What role can the states play to actually help enforce those and do more with those? I'll say another topic we didn't even talk about was like facility fees, right? And the difference between when someone where they get the service makes a huge difference in what it costs. In NYHPA, we have model legislation for states to try to really regulate against that, but it needs more support. Sometimes the state leaders just can't carry that themselves. They need other folks to kind of support that, because these are tough roads to walk down alone. So that's what I would say.
Thank you. Andréa?
We have sort of call to action for purchasers and what they should do, with their partners. And it's in one of the slides when that gets distributed. But unfortunately, I sort of have to say, people we need to shine a spotlight on, those that are not complying or are not fully complying with rules. And it really shouldn't have to be an enforcement issue. There should just be, if your question is about who in the system can, what should they be doing? They should be, following the rules and the requirements. The other thing, it's not entirely germane to this conversation, but I participated in and listened to a New York State Health Foundation presentation yesterday. And one of the places where consumers and patients have the ability to learn more about their health, not necessarily price and not necessarily quality, but in the spirit of transparency, is in open notes and their ability to read what is being said about them. And maybe that transparency and that access to that information, which is becoming more available, will help the progression of more quality transparency and more price information. So I would say, hold the system accountable for what it's required to do and shine a spotlight on those that aren't complying.
Great. Well, thank you. And thank you, all the panel members. Really appreciate all your insight and candor today. And with that, I'll turn it back over to Eric.
Great, thanks, Mike. Mike, thank you for moderating today's panel, and thank you to all of our panelists. Andréa, it's always great to see you. We're glad that you're able to be back again, because I think there's probably no better organization than CPR in looking at these issues. Hemi, it was great to have you. Certainly the work that goes on at the Academy is something that we look at on a regular basis. And Jeanne, I think your point about consumers now having a willingness to talk about healthcare and their costs, or taking that out of the shadow, I think that's another way of really getting at the issue of transparency, because if we don't talk about it, how can we fix it? So, and we're looking forward to to the work that you're doing around around COVID. So again, thank you to all of our panelists. This has been an excellent conversation. One programming note about tomorrow. We're going to start about 15 minutes later, so we're going to kick off at 10:30 instead of 10:15. But we have 3 great panel sessions to wrap up our third day and final day of our conference. We'll kick off with a panel discussion on state and federal efforts to address healthcare cost drivers. We'll wrap up the day with what's always been my favorite panel, A View from the Marketplace, where we'll get local stakeholders to talk about and expound on some of the issues that we've covered over the course of the last 3 days. And don't forget about our sponsored session, the customer experience in a post-COVID world presented by Cognosante. You're not going to want to miss a minute of these sessions, so please make sure to log on early. And otherwise, we look forward to seeing you tomorrow. Don't forget about the gaming challenge. You'll have one more day to check in with our sponsors and exhibitors. But otherwise, we'll see you tomorrow morning at 10:30. Thanks, everybody.